Hey, welcome back to the seminar series. This is session number 4. We'll be discussing the results. So now that we've been deep in the water, we're starting to come up. Before we reach the shore, we have to get through that massive layer of seaweed, okay? So that's where we're at right now. So let's trudge through the results. This is numbers heavy, so let's get into it. It might be a little longer than usual. Also, make sure you have the study with you as we go through. Okay, so here's a reminder of who the study participants were for the study. Remember this slide from the last session? So they gathered and assessed a group of children between the ages of 6 months to 35 months, or almost 3 years old, with a recurrent AOM. And remember, that was defined as either 3 or more episodes in 6 months or 4 or more episodes in 12 months. Then they excluded those who were on the list of the bottom half, on the bottom half of that left there, those with either previous surgeries or certain anomalies or defects that could possibly render them either more susceptible to infection or less susceptible to infection. And the right side of that slide just shows that great flow chart I love from pages 1790, 1791. All right. And here again is table 1, which shows the participants' characteristics in a table. And as you can see on top, there were 129 children in the tympanostomy group, 121 in the medical management group. Remember, those were the children who received antibiotics. And this gives them a total of 250 children in the final study. Now, I just briefly want to talk about what a regular randomized controlled trial usually entails. It usually entails traditional therapy for a certain condition, which usually acts as the control and compares it to a new therapy. But now in this study, they're comparing two different therapies. I'd say that medical management is more of the control therapy, and tympanostomy is the variable therapy. But there have been so many studies in the past that have compared these two therapies that really they're both conventional, that we have to birds now, right? Remembering the big picture of this study, let's remember what their main purpose of their study is. And that was to do the clinical trial with a longer timeline. They want to figure out if there's benefit of one therapy versus another after 2 whole years. So let's just keep that in mind as we go forward. Sorry that it was a little long-winded, but I thought those concepts were important. So here are the results I showed in session 3, which is in table 2. If you want to pause this, get your paper if you haven't done it yet to follow along. So let's make this a little bigger here. All right, here we go. And just make sure to notice that I'm also adding on the next 2 pages of tables, because in essence, those are part of the results, although the last graphic on the right is technically table 3. Okay, you see that? And so now this graphic shows all of the main results. Okay, now remember this slide from the last session? Let's just look on the left. So we talked about the primary outcomes and secondary outcomes. And their primary outcome for the study was the rate of AOM episodes per child for the 2-year follow-up period. And then the secondary outcomes, which were outcomes that, although not as critical as the defining primary outcome, were still very important to measure, are all listed on that slide as well there. Okay, so now we are going to go through the results as they pertain to those outcome measures. So we're going to use this table I made to more easily keep track of it. So let's look at the primary outcome measure, the rate of AOM episodes, or in other words, the rate of ear infections during the 2-year follow-up after their assigned treatment, okay? So this row is where we get those results. It's a comparison of the rate of episodes per treatment group. And notice that this row shows the combined rate for the full 2-year period. Okay, so we put those results onto our table, and we see that for the 2-year period, there is a slight difference in rate between the TTP group, the tympanostomy group, and the MM group, the medical management or antibiotic group. But we'll see in a minute that the results aren't significant. So this little extra tidbit I put on top right shows what they call the between group difference. So basically, if that number is 1, there's no difference between the groups. If that number is less than 1, the first group had better results. And if that number is more than 1, the second group had better results. So it's basically a ratio, okay? So the number we have is 0.97, which is just slightly less than 1, demonstrating that perhaps TTP is a little better than MM. But here's the catch. You see those numbers up there? See the range of numbers in parentheses, 0.84 to 1.12? And see up top, it indicates that this is the 95% CI. That's confidence interval. So what does that mean? Well, This is what it means. It means that they can say with 95% confidence that the number, although they got 0.97, the real number would be anywhere between 0.84 and 1.12, because this is just a study, it's just an estimate. And here's the catch. When the 95% confidence interval wraps around the number 1 in this calculation, it's showing that there is in fact no difference between the groups. And not only that, but their result also has what's called a p-value. Did you look up what a p-value was when I mentioned it in the last session? If not, that's okay. A p-value measures the degree to which the result is statistically significant. In other words, that the investigators got a result that is not just due to chance, but is likely that there is in fact a real difference between the groups. And the threshold for a statistically significant p-value is 0.05 or less. So this would mean that there's a 5% or less chance that the null hypothesis is true, or that there's no difference between the groups. Now, of course, no study can say that there definitely is or is not a difference. They just say that what the probability is that there is or is not a difference, okay? That's why they use statistics. So now I want to continue on to the next outcome measure, but I want you to notice one thing first about the primary outcomes, which is important. You know how we took the row that combined the 2 years? Well, I want you to briefly look at the rows that breaks each year separately, because you can see a difference, and this is important. Do you see how in the first row, the rates are not only larger overall, but there is a larger benefit of tympanostomy than medical management? And then the second row shows that not only are the rates lower, but the benefit now switches over to medical management, right? Do you see that? Why do you think that is? That is interesting. We can talk about that next session. Okay, let's move on to the secondary outcomes, and we'll see that with treatment failure. With treatment failure, it's defined in the study on page 1793 on the middle left. I have it right there on the slide in red, as basically the redevelopment of AOM episodes of the same rate as before, or parental request to switch over to tympanostomy in all children. Certain adverse events that are listed there, I won't go through them all, but they include adverse reactions to anesthesia, persistent otorrhea, which means drainage from the ear, tympanic membrane or eardrum perforation, hospitalization, etc. All right. So it shows that the treatment failure was much higher in the medical group than the surgery group. So I'm looking at that top row where it was 45% in the TTP group and 62% in the MM group. The numbers in parentheses are percentages. And not only that, but let's look at the confidence interval of that finding on the right of the table. And it shows the confidence interval to be 0.58 to 0.92. Now, remember what I said about the confidence interval last time? So does this confidence interval wrap around 1? No, it does not. So this shows that the benefit lies on the side of surgery when it comes to treatment failure. You see that? Okay, so we put those numbers on our table. Let's move on to time to first episode. Now, in order to do that, we have to jump to another figure, a graph on page 1798. Okay, so sometimes graphs can be confusing to read. So we look at the x-axis and the y-axis, and we see what they're measuring. So they're basically measuring the number of children who had their first episode at a certain time. And you can see that both curves demonstrate that there are a lot of children who have their first episode in the first 10 months. And in fact, it looks like depending on which curve you look at, about 60 to 80% of the children have their first episode in the first 10 months. Now let's compare the curves. So the red curve is surgery and the blue curve is medical therapy. And there were more children in the medical therapy group who had their first episode in the first 10 months than in the surgery group. You see that? So this right here is what I'm looking at. At 10 months, the blue curve is higher than the red curve, right? Okay, however, both curves then go on to level out at about 90% after 25 months. You see that? So this graph is saying that the time to first episode is much faster in the medical group. And in fact, according to their numbers on the top right of page 1795, it is 4.3 months versus 2.3 months. both groups do end up being even in percentage of first episodes by the 25-month mark. So it's just interesting to note. But that time to first episode is an important secondary outcome. So we'll put that in our table here. Now let's move on to frequency distribution of episodes. Okay, so here's the area in the table that displays the numbers for the frequency distribution. So what it's showing is the number and percentage of children who either had 0 episodes, 1 or 2 episodes, 3 or 4 episodes, or more than 5 episodes, okay? And as you can see, there are fewer children in the surgery group than the medical group who had 1 or 2 episodes and also 3 to 4 episodes. But there are a lot more in the surgery group who had 5 or more episodes. So all of that is difficult to cumulatively quantify. But the authors do state on page 1795 here that no substantial differences overall were apparent between the groups regarding that frequency distribution, although they didn't cumulatively quantify it, which is interesting, but we just take the table and we'll label that row ND for no difference. All right, let's move on to percentage of severe episodes. Okay, so here's the section that indicates severe episodes. And we'll see on the bottom row that there's a slight advantage for the tympanostomy group. But let's then also look at the numbers on the right that show the between group difference in the confidence interval again. And although the between group difference shows 0.91, which gives the advantage to the tympanostomy group, the confidence interval again wraps around 1. And so statistically, there is no difference. But granted, we can still note that the confidence interval does lean a bit towards tympanostomy, but we're just reporting the results here. Okay, so we put the result in the chart. Let's move on to days with otorrhea or antibiotics, and we're going to speed through the rest for the sake of time here. Okay, so these areas here are where they show this results for tube otorrhea and antimicrobial treatment, both of which they define to be secondary outcomes and adverse events. And I believe that there are some limitations with these outcome measures, but we'll get into that in the next and last session where we discuss the conclusions. Now I want you to notice the table on the right also has the overall rate of tube otorrhea there, but this outcome measure is referencing the number of days with tube otorrhea. So we take that from the table on the left. Okay, so we put in the numbers and note that there are 2 different results in the chart. Otorrhea is the first one, antibiotics is the second one. And I did not add the confidence intervals because they don't wrap around 1. So the numbers are real there. And to be clear, let's just define tube otorrhea. I mentioned it before, but tube otorrhea, by conventional definition, is fluid coming out of the ear. So if you've ever had an eardrum perforate when you were younger at all, you'd know that fluid comes out of the ear after the membrane perforates. But keep in mind, there's both clear fluid and purulent or infected fluid that can come out. And this study doesn't define this outcome either way. So we can just assume it's any fluid, but we'll discuss this further next time. Okay, let's report on diarrhea or diaper dermatitis, both outcomes that basically are a reflection of a changed environment in their intestines, right? And these numbers can be found on the table on the right. And we'll notice the numbers in parentheses because those are percentages, not the raw numbers. And it shows that more children experience diarrhea or diaper dermatitis, which is kind of like a little rash on the bottom, in the medical management group, but the confidence interval actually wraps around 1 for both of them. So let's note that. Okay, so we have those numbers down. Let's report on antimicrobial resistance. So I won't talk a lot about this, but here's a good depiction of how antimicrobial resistance occurs. Basically, what it is when a provider puts a patient on antibiotic and that antibiotic doesn't work because the bacteria in the infection is actually resistant to that antibiotic. And then they have to choose another antibiotic that's either stronger or another category. And this is becoming a really big problem in the medical community. It's a very interesting subject if you wanted to look it up and learn more about it. But the authors really don't talk about this much at all, except their very brief mention that between group differences were insignificant right here on page 1798. Okay, so we're just going to fill that in with ND for no difference again. Now we'll look at quality of life assessments. And these assessments are explained in detail in the paper. But as you can see, for the most part, there really isn't much of a difference in the assessments between the groups. And the difference was we do see, we notice on the right that the confidence interval does not show significance. Now in these calculations, 0 would be the null hypothesis. Remember I had 1 as the null hypothesis up above? This now it's 0, meaning there's no difference between groups. And as you can see, all of these results wrap around 0. It's just the way they did the calculations, that's all. So you see that here in yellow. I apologize for my rudimentary graphics. I'm sure most of you could do much better than this, but hey, you get the point. So we just take the table and fill that in with ND for no difference too. So for parental satisfaction scores, those were assessed on a 5-point scale. There is a small difference, 4.64 versus 4.43, but the confidence interval again wraps around 0. So we can't be confident that this interval isn't just from, this difference isn't just from chance. So we just take the number, take the table and fill that in with the numbers, but we'll just note the confidence interval, okay? As of the use of the other resources, the author defined this as, let's say, either additional medical resources other than that received for the trial, or other non-medical resources, such as special care arrangements that directly have to do with the procedures and consequences of the study, okay? And since there are few numbers with those results, but the numbers wrap around 1, there's essentially no significant difference. However, it is interesting to note in general, if you go back and you look at those numbers, that it's a surgery group which needed more resources, which obviously would make sense. If a child is getting surgery, more resources are going to be needed. So now we have finished the table of results for all the outcome measures. So before we wrap up for this session, let's look at this table here. Now I've highlighted all the results that have significant differences between the groups as they pertain to the outcome measures in this study. So the primary outcome did not have a significant difference. And the only secondary outcomes with a significant difference included the percentage of children with treatment failure, which favored the surgical group, the time to the first episode of infection, which again favored the surgical group, days with tube otorrhea, which favored the antibiotic group, and days with systemic antibiotics, which favored the surgical group. So that's it for today. Today was the results. We trudged through those results and we got it done. Great job. And now next session, we'll discuss what it all means and we'll put it all together. So I will see you all then in our 5th and final session of the series. And of course, email me if you have any questions or need help. It's been great hearing from all of you. There have been some great questions. Also, subscribe to the Pre-Med Scenes YouTube channel so you can automatically get a notification when the next session drops. And of course, sign up for emails from the Pre-Med Scene website, because you not only get info about this series and our fall journal club coming up, but all the great content that the Pre-Med Scene provides. See you all in session 5.